Immune checkpoint inhibitors like pembrolizumab allow the body's own immune cells to detect and aggressively destroy cancer cells, leading to complete tumor eradication in some patients. But removing the brakes on the immune system comes at a cost. The same aggressive immune response that targets tumors can also attack healthy tissue, resulting in immune-related adverse events. One of the most elusive and life-threatening of these complications is capillary leak syndrome, or CLS. Mastering the identification and management of CLS is a critical clinical skill. Recognizing it early allows for intervention. Missing it can lead to fatal, unrecognized hypovolemic shock. This diagram illustrates a cross-section of a healthy blood vessel. Notice how the endothelial cells are tightly secured by interlocking bonds called adherence junctions. These structures keep protein-rich fluids safely contained inside the vessel walls. When an overactive immune response targets these cells, it attacks the vascular endothelial cadherin. The interlocking bonds break apart, creating widening gaps directly in the vessel wall. With the junctions breached, the vessel loses its structural integrity. Yellow protein-rich fluid aggressively escapes the vessel and pools in the surrounding tissue, leaving the interior of the vessel physically depleted and shrunken. This fluid shift creates a dangerous clinical state. Because the fluid moves entirely into the surrounding tissue, the patient develops severe external edema while simultaneously crashing into hypovolemic shock within the bloodstream. At the bedside, this massive fluid shift presents rapidly. You will see severe anasarca, profound fatigue, and a sudden weight gain, sometimes 20 pounds in a matter of days. You may also observe a rash or lower extremity vasculitis. Alongside the severe swelling, the patient's vital signs will signal crashing hemodynamics. Look for daily fevers of unknown origin paired with persistent hypotension that does not respond to standard interventions. This interface shows a typical metabolic panel for a patient with CLS. The two critical markers you need to pinpoint are severe hypoalbuminemia, dropping as low as 2.0 grams per deciliter, and significant hyponatremia, falling to 125 millimoles per liter. Because the intravascular volume is depleted, renal perfusion drops sharply. This inevitably leads to an acute kidney injury, compounding the patient's metabolic distress. When severe edema occurs alongside hypovolemic shock and plummeting sodium and albumin levels, the clinical picture points toward capillary leak syndrome. Suspecting it at this stage is vital before the lack of perfusion causes irreversible organ damage. There is no single blood test or imaging scan that confirms capillary leak syndrome. It is a diagnosis of exclusion, meaning you must systematically eliminate every other common cause of edema and shock. Step 1 requires checking the endocrine and renal systems. You must work with endocrinology to rule out adrenal insufficiency and hypophysitis, while nephrology rules out SIADH, low solute intake, and diuretic-induced hyponatremia. Next, you move to infectious disease and rheumatology. You need negative blood and urine cultures to rule out systemic infection, and a clean antibody panel to eliminate autoimmune vasculitis or lupus. If the workup is negative and the patient presents with hypervolemic hyponatremia and poor renal perfusion that persists despite fluid restriction and diuretics, the diagnosis shifts to capillary leak syndrome. This multidisciplinary workup demands strict clinical discipline. Assuming CLS without excluding sepsis is dangerous, as immunosuppressants will accelerate an infection. But delaying the workup risks delays in delivering the treatment the patient actually needs. When starting resuscitation, there is a specific error to avoid. Because the patient is hypoalbuminemic, it is tempting to administer an albumin infusion. However, because the vessel walls are compromised, those small protein molecules will simply pass straight through the gaps and pull more fluid into the interstitial space, worsening the edema. The correct first line of defense is aggressive support and immunosuppression. Use IV crystalloids to maintain intermuscular volume, immediately halt the immunotherapy, and initiate systemic steroids, typically IV methylprednisolone. You now have a 48 to 72-hour evaluation window. You are looking for a clinical response, rising blood pressure, decreasing fever, and stabilizing lab values. If the sodium and albumin levels remain low or continue to drop, the patient is failing to respond to steroids. At this point, you must escalate treatment. When steroids fail to close the vascular leak, Immediately initiate intravenous immunoglobulin, or IVIG, for 5 consecutive days. Executing this two-pronged attack is the only way to rescue the patient. You must use fluids and pressors to maintain intravascular volume, while simultaneously using immunosuppression to stop the leak at the cellular level. As the adherence junctions repair, the fluid shift reverses. The patient's blood pressure will stabilize, they will experience profound diuresis as the interstitial fluid mobilizes, and their sodium and albumin levels will return toward their baseline. Remember to contrast this presentation against its common mimics. Heart failure or kidney failure can cause severe edema, but they do not typically present with the sudden vascular collapse and extreme hypoalbuminemia seen here. Trust the combination of severe tissue fluid overload paired with intravascular shock. By maintaining a high index of suspicion, adhering to a rigorous diagnosis of exclusion, and rapidly initiating steroids, clinicians can effectively stabilize and resolve one of immunotherapy's most lethal complications.